iPhone 10, and then now the next version is iPhone 11, for example, then there's going to be some small change in the manufacturing process, and then not necessarily is the solution that you've developed before going to be applied. It can be transferable, and it can be usable. So in that scenarios, then what you need is an adaptable problem solver that can look at the situation and adapt the way it finds the solution based on what happened.
Thanks, Dr. Su. Let's move into the next session. Yeah, we have Professor Alex Cook. He's an associate professor at NUS School of Public Health. He's also the vice dean. He works on infectious disease modeling and statistics, including dengue, influenza, and other respiratory pathogens, and on population modeling to assess the effect of evolving demographics on non-communicable diseases such as diabetes. His multidisciplinary team brings together researchers from fields of statistics, computational biology, computer engineering, mathematics, geography, and environmental sciences. I'm grateful to have Professor Alex Cook here with us with a short invitation that we sent to him. And I would like to ask Professor Cook to continue his presentation on using data analytics and modeling to inform policy during pandemic. It's very relevant for us today across the world. So I will let Professor Cook take over from here.
Okay, well, thank you very much. It's really a great honor to be able to be with you today. It's a shame I can't be there in person, but maybe after the pandemic is over. So I hope you can see my slides okay. So as mentioned, I am from the School of Public Health, where I am in charge of the modeling and statistics group within the school in the National University of Singapore. And because Singapore is such a small country, we have very close relationships with our government because there's only a few universities in the country. And as a result, it is quite gratifying to be able to translate the work that we're doing as part of our research and actually see it being translated directly into policy. So what I'll be talking about today over the next 20 minutes or so is some of the ways in which we're using both modeling and analytics to inform some of the government's response to the pandemic. It'll be a very Singapore-oriented presentation, but I think that, I've been following the news in Sri Lanka, and I think that some of the experiences that we've had will also be relevant for what you're experiencing. So I don't think that I can never remember a time in which modeling and modelers has been on the news quite as much as it has been over the last year or so. It's almost a weekly occurrence that we have the local news in Singapore asking us for comment about what the current situation is like. So it might make it seem as if modeling is something that has been really quite new in the field of preventing infectious diseases, but that is not really the case. If you go back over 100 years ago, there's a paper in volume 1 of the British Medical Journal by Ronald Ross, in which the second paragraph there you can see has a series of ordinary differential equations. Ronald Ross is quite timely. He won the Nobel Prize in Medicine for his work on malaria transmission. But actually, despite winning the Nobel Prize in Medicine, he actually felt that his work in furthering what he called pathometric equations, but what we would now call mathematical epidemiology or mathematical modeling, was his proudest achievement of his career. Now, so it's at least 100 years that people have been doing modeling or analytics to help control infectious disease outbreaks. Actually, it's even longer than that. If you go back to 1760, there's a paper by Daniel Bernoulli from the Bernoulli family, in which he demonstrated the impact of different, sorry, it's in French because he was French, of course, of different ways that you could try to use inoculation to prevent smallpox. And this, I should say, was about a decade or so before Edward Jenner actually first developed the first inoculation. So already mathematicians were leading the way in that regards. So my plan for the presentation is that I'm going to start by talking a little bit about how modeling in general is used. And then at the second half of the presentation, I'll talk about some of the specific examples from my team's work here in Singapore. Okay, but let's start with some fundamentals. One of the key quantities that we use to try to describe how bad a pandemic is going to be is an attempt to measure transmissibility. And you've probably seen this in the news because you know, like places like the UK are reporting what their R number is. What is this R number? So it's an attempt to quantify transmissibility of a virus or any other pathogen. So to understand this, let's just go through a very simple thought experiment. Imagine that you are infected with a virus, for example, let's say it's SARS-CoV-2. And the question is, how many people are you going to infect before you recover from it? So to understand or to start quantifying this, it's good to break down how many people you're going to infect into the different kind of groups. So the people that you know in your social network. Let's assume that you don't, it's a contact transmissible disease. You're not going to infect anyone unless you come into contact with them. Let's say that you know N people in your social network. This is usually around about 200 or 300 people. Now you don't come into all of those people on a daily basis. You don't come into contact with all of them in the period that you're infected for. And so you maybe only come into contact with a proportion C of these N people, right? So it means that C times N, that's how many people you come into contact with while you were infected. Now you don't infect everyone you come into contact with, like you might be wearing a mask, for example. And so let's say that for every person you come into contact with, there's a probability V of virus transmission, but then not everyone that you try to infect with the virus will actually be infected. So there's a probability H that the host gets infected. So given all that, how many people would you infect? Would you believe on average that you would infect? Well, it's quite simple. It's just a product of these. So N people in total, N times C people you come into contact with, N times C times V you try to transmit infection to, N times C times V times H you succeed in infecting. Okay, so this is called the basic reproduction number, or the R number. And it is one of the key ways that we say how transmissible a virus is. I have colored the different letters because the reproduction number is a combination of both social and biological factors. You can control the ability of a person to infect someone else by giving antivirals, for example, right? That's a biological factor you're able to control. In the beginning of an epidemic, we don't have that kind of antivirals or vaccines. And so we don't have biological means to prevent transmission. And so what that means is that we would instead use social ways to prevent transmission. For example, I see many of the people in the DataSEARCH room are wearing masks. That's one of the ways that we can introduce in order to prevent transmission in a social way, from looking at the C factor, for example. Now, let's just have a very quick quiz. How transmissible are these three viruses? Right? It turns out measles is the most transmissible, Ebola is the least transmissible. So there's ways that you can try to estimate transmissibility. For example, by looking at the early period of an epidemic, before you have control measures in place, then you often see an exponential growth in the number of cases, and that you can translate that into a growth factor, which translates into a reproduction number. So people have estimated what the reproduction number in some societies might be for these three viruses. I think that shows the importance of separating out transmissibility from the overall impact, right? So the severity of an outbreak is not going to be determined by, sorry, let's get rid of the poll, it's not determined only by the frequency at which that pathogen appears in the population. That's determined by the transmissibility, but it's also by the severity. I think most people in the audience would rather get measles or SARS-2 than to get Ebola, because Ebola has a case fatality rate somewhere like 40–50%. Okay, so the overall impact of a disease will be a mixture of both how transmissible it is, how rapidly it spreads, as well as the impact of any particular person who gets infected. Now, one of the reasons why SARS-2 has been so much worse than SARS-1 is that it is actually milder than SARS-1. And that makes it less easy to change the transmissibility because people don't adhere to those behavioral factors as much as they would during the SARS-1 outbreak of 2003. Now, the reproduction number actually quantifies a very important behavior, which is whether an epidemic can grow or not. And I'm going to show you this with a little cartoon. Let's say you got a plane load of tourists, let's say from China, come into Sri Lanka, and there's 10 people infected on the plane. Then those 10 people in the next generation will infect 20 people, they'll infect 40 people, they'll infect 80 people, and you'll end up with a growth which looks fairly constrained on this chart, but actually is exponential, and you'll see that in a second. If the reproduction number is smaller than 1, let's say it's a half, then you start with 10 people on the plane, they're only able to infect 5 people, they infect 2 or 3 people, they infect 1 person, and then you've got the epidemic dying off. Right, so it's this kind of, this level of 1, which is the threshold which determines whether an outbreak can sustain itself in the population. Above 1, that means that epidemic will grow. Below 1, epidemic will shrink and eventually die out. Now, one of the beauties about this way of conceptualizing the epidemic is that although it's very simple, actually it creates a dynamic behavior which mimics what we see in real life. So just by having each person creating an average number of secondary cases, we end up with an exponential growth in the number of infections over time. So here I'm starting off with, I think, 10 infections in generation 1, a reproduction number of 2. Let's say it's in a population of size 5 million like Singapore. How long will it be until everyone in the population gets infected? Will it be 100 generations, maybe 200 generations? Actually, no. It's really counterintuitive. People don't understand exponential growth on an intuitive basis. Oh, no, it's not Singapore. Oh, I did it for Sri Lanka, about 20 million, right? Oh, good, I must have changed the slide. So for Sri Lanka, then you'd have that within 30 generations, effectively the entire population has been infected. Not quite everyone. Some people will escape infection entirely, but you have that such a rapid growth towards the end in absolute numbers that you can't, in a way, intuition doesn't really predict what's going to happen from the beginning part. Okay, maybe easier to visualize. So sometimes you'll see that some of the charts that were presented in the media and the mass media at the beginning of the epidemic were on a logarithmic scale. The reason for that is because it shows much more clearly how that growth can be constant and unending all the way up until you end up with almost everyone infected in the population. Now, one of the great beauties of this approach to understanding transmission is that it tells you, even at the beginning of an outbreak, how big that outbreak is going to be. That's one of the reasons why we were taking SARS-2 so seriously at the beginning and back in January and February, because we could tell from the reproduction number that this was going to be a serious problem. So let me just, let's do that calculation that I showed you there, using my hand to try to show it, but you don't have video on, so you can't see it. How that growth would happen for the 3 pathogens that I introduced earlier. All right, so I'm tabulating there what final fraction of the population would get infected just by evolving this model forward in time. And I'll plot that there. I'm cheating a little bit for measles because I can't fit R0 of 18 onto the chart, so I'm going to pretend it's 5. It's more or less the same, so so that will make it a bit clearer what's going on when I visualize changes in a second. So it's actually fairly easy to derive what the equation that connects those points up. It looks like that. So up until reproduction number 1, the final attack size is effectively 0, and then beyond that it grows rapidly. Note that even a reproduction number of, let's say, 1.2 can still lead to maybe 20% of the population becoming infected. Now, the important thing with this is that it means that if you can estimate the reproduction number all the way at the beginning of the epidemic, then you can tell already how big it's going to be at the end. So for example, Zika with a reproduction number of 2, which is the same as SARS coronavirus, would infect 80% of a population if it's left unchecked. Right? And so it also tells us how much effort we have to put into control if we're going to stop that outbreak from happening. So for example, if we implement social distancing which reduces the fraction of contacts by, let's say, a third, what will the impact be on these three viruses? Right? So if you can reduce contact by a third, has no impact at all on measles, it still effectively is going to infect almost 100% of the population. But with Ebola, it's no longer going to cause any threat. Right? So that tells you that to prevent an Ebola outbreak, you just need to reduce transmissibility by a third. That won't be enough for a disease like Zika or like COVID, because the reproduction number of 2 would only be reduced to, what is it, 1.3 or something, which still leads to about 40 or 50% of the population getting infected. So to prevent a COVID outbreak, we need to reduce transmissibility by a half. Right? And that's one of the reasons why we have so many countries have launched into mass lockdowns in order to try to get that transmissibility down to a lower level. So in the next 10 minutes, I'm just going to present some of the work that we're doing in my team at the School of Public Health in National University of Singapore to inform the overall government's response. There's many different ways that we can do it, and I would say it's a mixture of modeling, like what I presented before, as well as analytics. Now, one of the differences, I think, between the work that we do and what Dr. Nguyen presented earlier is that we don't have big data typically in public health. So we're often having to work with much smaller data sets and trying to eke out as much information as we can from those small data sets. So we develop models which try to fuse together information from different places. So for example, to evaluate policies, let me show you one of the ways that we try to do this. So we developed quite complex individual-based models. In fact, our team published the first individual-based model of COVID in Lancet Infectious Diseases way back in, I think, March or something. And the way that we do this is that we develop a highly detailed representation of the resident population of Singapore, where they live, where they work, where they go to school, who they live with, who they work with, etc. And then on top of that, we can overlay parameters that characterize the transmissibility of the virus. And then because we're representing things like schools in the model, we can say what happens if we introduce school closure. Well, what impact is that going to have on overall disease? So in one of our early papers from back at the beginning of the year, we showed the importance of having a fast response to the outbreak and a multi-layered response. So all countries are required by the WHO to have a pandemic preparedness plan, which is like a book which has a list of what different policies that they will introduce in the event of a pandemic. We're usually conceptualizing a flu pandemic because that's most of the pandemics we've had over the last 100 years have been flu pandemics. And one of the problems is that with that like book of strategies, most of the strategies have not actually been used in recent memory, and so we don't know what the effect is going to be. So we can't just use analytics to try to show what the effect is from like past outbreaks, because we haven't done workplace distancing and mass school closure for past outbreaks in the way that we have now. So what we do is we represent that within a simulation model, and then we say what would happen if we just do quarantine, or we just do workplace distancing, or we just do school closure, or we have to combine them all. And when we do that, it shows that we really need to have all those measures if we're going to substantially slow down the epidemic enough to build up ICU capacity and testing capacity. And that's one of the things that Singapore implemented. I think Sri Lanka did as well. It's one of the things that many European countries did not, and that's one of the reasons why they had such large outbreaks earlier in the year. Now, it's not just using, we don't just use models to understand transmission. So for example, well, I mean, everything is a model, but it's not just simulation models we use. So for example, we have very good contact tracing in Singapore, probably one of the world's best, I'm sure. I mean, not quite as good as Korea, but still pretty good. And from that, we've got very rich data on all of the people who've been infected with potential links between them, but we're often not exactly sure what those links are. So we can use statistical methods such as data augmentation, Markov chain Monte Carlo to impute the missing links between individuals, or to impute the partially observed links. So for example, I might be connected back to two of my colleagues. We're not quite sure which colleague, but by looking at the timing of which we have onset of symptoms, we can get a better handle about who infects whom. And from that, we can infer both the transmission tree as well as estimating in close to real time what is the reproduction number. So what I'm showing you there, the blue curve, which is a bit hard to see in amongst points, around about 1, that is our estimate for the reproduction number in Singapore. So it's much lower than what we've seen in many other countries, and that's because of the intense contact tracing measures that we've got. Okay. Right. Now, one of the other things which I think differentiates between many Asian countries and many European or American countries is that we take quarantine and isolation very seriously in Asia. And so the people that we identify through contact tracing, quarantine them at home, at least in Singapore we do. And then all of the cases are getting isolated either in a hospital or a healthcare facility. And so we can use that individual-based model to assess what the impact is of a European or an Asian style form of isolation. We can see massive differences in the overall proportion of who will be infected if you are isolating people away from their families, or you allow them to remain with their family where they can, of course, infect the household. Okay. Now, the final thing that I'm going to talk about before I wrap up, because I realize I'm talking a bit too long, is that we're currently discussing with our government about how we can use analytics and modeling to understand what is the risk of importation as we start to reopen the borders. I'm just going to skip to this slide for a second. If you look at the red chart at the bottom, you can see the number of imported cases. We had this big rise back in March, and this was mostly Singaporean students fleeing from Europe and America, trying to get out as the first waves hit in the West. And that led to, if you look on the upper chart, a series of infections in the community, which eventually led to lockdown, the part in gray. And so we were very anxious. So ever since then, we've been quite careful about reopening the border. It's only been in the last month or so that we've been starting to reallow countries or travelers from very low risk countries like New Zealand or Brunei to re-enter into Singapore. So the way that we are trying to assess this is effectively by simulating large numbers of passengers and looking at what would happen on them if they were to get quarantined for, let's say, a week or 2 weeks, or if they're going to get tested, or if they get tested before they fly out, or tested on arrival, or tested while they're being quarantined. As we've already published some work on this, but what we're looking at now is a much larger set of scenarios. It goes beyond just the 6 that I'm mentioning here, to try to assess what would the impact be of some of the border policies that the government is currently looking at, such as, for example, doing rapid tests on arrival at the airport. Okay. So I hope that's given you a bit of a sense of some of the ways that we can actually deploy the analytics and modeling work that the data scientists can do, and not just do it for publication, but also to translate it into policies. I should thank my funders, the people who did the work. And if you want to read some of the work that we have published, you can take a look at it on our Google Scholar. And I'll also be very happy to receive questions and comments. And if you want to talk in more detail at a later point, I'd also be glad to do that. Thank you very much for your attention.
Thanks, Professor Cook. If you have any questions, we can actually open, because we have about 5 minutes. If you want to ask questions, you can unmute yourself and ask. Okay. Yeah, we have a few questions.
Oh, fantastic questions. Maybe I'll start with the mass testing question, perhaps. So I think the mass testing is really important. It's an important ingredient in testing and isolation and tracing policy. And that's one thing that we see that, you know, countries like the UK, where I'm originally from, have really messed up with, in that they bought themselves some time by going into a lockdown earlier in the year, but he didn't use that time to get a testing system set up. So of course, you can only isolate people if you know that they're infected, right? And that's one of the reasons why testing is so important. It's important to have that capability to identify rapidly who's infected, so you can get them out of general society and get them into somewhere where they can be monitored and checked to make sure that they're okay. Now, one of the other ways that you can use testing is to try to identify those either asymptomatic or mildly symptomatic individuals that are still responsible for a lot of spread, but because their symptoms are mild and perhaps confused with other respiratory infections like flu or cold or something, that they wouldn't necessarily present into the system, and so they may be infecting, let's say, their elderly family members, but not know that they've got COVID. So that's one of the key uses of mass testing, will be to try to identify those kind of low-grade infections. I think another form that mass testing can be really useful is for clearing mass events. So we're starting to discuss now in Singapore having things like academic conferences resume, or concerts and so on. And that's something that can only happen if we're quite confident that there's not infections lurking amongst the people in the audience. So what we're thinking about now is we've got rapid tests that can give you results that are fairly accurate in, let's say, 15, 20 minutes. Then people could be cleared for entry into a conference at the beginning. And if it's a short conference, that might be enough just to make sure that you're pretty confident that the place is safe. So that's that. So I think there's a big role for mass testing, and I would highly recommend it. Shall I, maybe the second question is also very interesting. So there's some discussion just now in the media about this Great Barrington Declaration, which a few scientists have signed, and that is kind of like bringing back the concept of reaching herd immunity through naturally acquired infection, which was first discussed in a few countries in the West, like the UK and Sweden, way back in their spring. So the idea of that is that if you, that eventually the only way that we're going to stop the pandemic is by getting to herd immunity. It's either going to be that we get herd immunity through vaccination or through infection. The vaccine is actually much closer now than it was at the beginning of the year, which is why I find the current discussion about trying to get to herd immunity so crazy, because we're almost there. We've been through so much. Let's just manage a little bit longer. But that discussion about herd immunity, the idea there is that you could have younger people get infected. They don't have such severe infections. Therefore, that might be one way that you can kind of get to an end quicker without risking a lot of death and a lot of economic damage. The problem with this strategy, as I see it, is that it's not possible. It's twofold. It's not possible to isolate high-risk people from the general population, right? You got, an 80-year-old woman living at home. I mean, she's not going to live by herself. Often she'll have family members that need to take care of her or something. And so I don't think it's possible to completely segregate the population into low and high risk. The other reason why I think it's problematic is that we're starting to get more of a handle on the risks of younger individuals, right? Like there was some talk about some sequelae in children, for example, as well as like working age adults who suffer from long COVID, which is months after they should have recovered, and yet they're still suffering from like brain fog and other cardiovascular symptoms and so on. So I think that herd immunity in most countries probably is not a viable strategy. An example of Sweden is a good example of that. Over.
There's another question on the chat. I don't know whether you can see that.
Oh, dynamic Bayesian model. Yeah, that's another good question. So one of the big problems that we have with things like those agent-based models are so complex that trying to fit it in a statistically valid way to data in real time is just not a feasible outcome. And so when we try to make forecasts of what we think is going to happen next, actually the approach that Delaney's talking about there, which is having fusing information in a simpler model, I'm using that to project forward, that's actually a quite viable strategy. So we have for some time been working with our government to provide them dynamic forecasts from a simpler epidemic model fit to data, updated daily, and we use that to inform the healthcare requirements that they need to have. So, for example, in having, how many ICU beds need to have. One of the big worries at the beginning of the pandemic is we did not have enough ICU capacity, and partially as a result of our models, the government built more ICU capacity just to be on the safe side. Turned out we didn't need all of that capacity so far, but touch wood, let's hope that we still don't need it by the end of the pandemic.
Do you have any other questions? Or Dr. Cook, I have a question for the first simulation that you were talking about. How did you model the mobility of people in Singapore?
That's a very good question. Yeah, there's a lot of very good questions. Okay, so there's a few ways to try to do this. Several big data companies like Google, for example, provide data which allows to get some handle on this. I'm actually going to just bring up my slides again, because I did have a slide that I skipped over a little bit. Let me just show it again. How do I get back to the slide that I was going to show? Here. All right, so this is Google mobility data that we harvested a few months ago. So let me just let's talk my way through it a little bit. You can see the shaded colors. Circuit breaker is the Singapore name for lockdown. Then we had phase 1 of post-lockdown and phase 2 of post-lockdown. And during that time period, different measures were implemented to restrict movement. And so one of the great things about having this kind of mobility data is it gives a more immediate way of assessing what the impact of that policy is. So, like if you look at the beginning of the circuit breaker period, the government had insisted that people would stay at home, for example. So only essential workers like modelers were allowed to keep on going to work. And at the beginning, we don't know what the impact of that is going to be on transmission, because what we'll only start to see the impact of it in 1 to 2 weeks after you've had a few generations of infection. However, with Google mobility data, you're able to see immediately that there's a huge rise in the proportion of people who are spending, or proportion of time spent at home, and a huge fall of over 50% in the amount of time spent at work or in everything apart from essential shopping like groceries. So I think it has a real role, and that's one of the ways in which analytics rather than modeling can have a big impact. Now, one problem with this is that actually we found that Google were being quite slow in releasing these data. So I think that when we needed them, it was like 1.5 weeks or 2 weeks out of date, and so I actually didn't provide that extra speed to understanding the impact of the policies that we would have liked to have had, unfortunately.
Okay, thanks, Professor Cook, for that very interesting presentation on